Hi, everyone. Welcome back to the podcast. This episode is going to be based on Chapter 23 from our Neuroscience Fundamentals for Rehabilitation by Lundy-Ekman, and we are going to be diving into the vestibular system. I just want to apologize in advance. My house is crawling with children, and if you hear background noises, I apologize. I have tried to bribe them with a lot of snacks so that they keep quiet while I'm talking, but wanted to give you a heads up. So now let's chat a little bit about the vestibular system. We're going to learn about how it works, why it matters, and what happens when it goes wrong. If we start with our big picture, the vestibular system plays a critical role in several essential functions. It provides sensory information about head movement and position relative to gravity, helps stabilize gaze when the head moves, contributes to postural adjustments, and even influences autonomic function and consciousness. And at its core, the vestibular apparatus contains sensory receptors that detect head position and movement, converting all that information into neural signals. These signals are then carried by the vestibular nerve to the vestibular nuclei. So where does all of this begin? The peripheral vestibular system is located at the inner ear. It all consists of bony and membranous labyrinths. Between these structures is perilymph, a fluid, while the membranous labyrinth itself is filled with endolymph, another fluid. Within the membranous labyrinth are hair cells, which serve as receptors. When these hair cells bend, they change the rate of firing signals carried by the vestibular nerve. Now let's zoom in to one of the key components, the semicircular canals. There are three semicircular canals that work in pairs. These include the horizontal pair, the right anterior with the left posterior, and the left anterior with the right posterior. These pairs operate on a push-pull system. When one canal increases its firing rate, the partner will decrease. This reciprocal signaling is essential for normal function. If the signals are not reciprocal, problems will arise with posture, eye movements, and even cause things like nausea. From rotation, let's move to linear movement and gravity. This is where the otolithic organs come in. The utricle and saccule are membranous sacs known as otolithic organs. Unlike semicircular canals, they are not sensitive to rotation. Instead, they detect head position relative to gravity and linear acceleration or deceleration. Inside these structures is the macula, which contains hair cells embedded in a gelatinous layer. On top of this layer are otoliths, also called otoconia. They are small calcium carbonate crystals that are denser than the surrounding fluid. When the head changes positions, the weight of these crystals shift the gelatinous layer, bending the hair cells. This bending either stimulates or inhibits the cells depending on the direction and alters the firing rate of the vestibular nerve. So what does the brain do with all this information? Information from the semicircular canals helps stabilize the vision, keeping eyes fixed on a target while the head moves. Information from otolithic organs help adjust activity in the lower motor neurons that control postural muscles. All of the sensory input is transmitted by the vestibular nerve, which connects the peripheral vestibular system, made up of the semicircular canals, otolithic organs, and the nerve itself, to the vestibular system, the central vestibular system. The central system includes vestibular nuclei in the medulla and pons, as well as flocculundular lobe of the cerebellum. Now, let's talk about how the vestibular system interacts with vision. There is a concept called reciprocal inhibition between the visual and vestibular systems in the cerebral cortex. Essentially, these systems inhibit each other. When vestibular activity increases, like during rapid head movement, visual detail is going to be reduced. You've probably experienced this. When you turn your head slowly, your vision stays clear. But when you turn quickly, things begin to blur. This happens because the brain is prioritizing motion information over fine visual detail during rapid movement. Now let's look at what happens when things go wrong. The most common symptom of vestibular dysfunction is vertigo. this false perception of movement. Vertigo can be physiological or pathological. Physiological vertigo occurs due to sensory conflict, such as when you stop spinning, your vestibular system continues signaling movement. Pathologic vertigo occurs in both facial orientation processing. Other symptoms of vestibular disorders include nystagmus, unsteadiness, ataxia, nausea, and vomiting. People that experience vertigo may feel like they or their surroundings are moving, and they often need to move slowly and focus consciously to maintain balance. Let's break this down into further peripheral disorders. Peripheral vestibular disorders typically cause recurring vertigo with moderate to severe nausea, and nystagmus is almost always present. Certain medications can also damage the peripheral system. One of the most common conditions is benign paroxysmal positional vertigo, or BPPV. This condition is characterized by a sudden position-triggered vertigo and nystagmus. Let's break down the words. Benign means it's not life-threatening. Paroxysmal means sudden onset, and positional means it's triggered by changes in the head position. In BPPV, displaced otoconia or crystals move into the semicircular canal, most often the posterior canal, a process called canalithiasis. Rapid head movements cause these crystals to shift, leading to fluid movement, stimulation of hair cells, and resulting in symptoms. These episodes are brief, typically lasting less than a minute, even if the position is maintained, the head position. A less common form is called cupulolithiasis, where the otoconia or crystals attach to the cupula instead of floating freely. This leads to more intense symptoms, longer duration, no latency or delay before the onset of symptoms, and symptoms that persist as long as the position is maintained. Another peripheral condition is vestibular neuritis, which is an inflammation of the vestibular nerve, often caused by a virus. Symptoms of vestibular neuritis include severe vertigo lasting up to 3 days, spontaneous nystagmus, nausea, and unsteadiness. Importantly, hearing is not affected. Caloric testing in these patients shows decreased or absence response on the affected side. Meniere's disease is another condition characterized by sensation of fullness in the air, tinnitus, vertigo, nausea, vomiting, and hearing loss. It is associated with abnormal fluid pressure in the air. Treatment often focuses on symptom management, and in severe cases, surgical intervention may be considered. Traumatic injuries can also affect the vestibular system, including concussions, fractures, and pressure changes in the inner ear. There are also causes of unilateral and bilateral vestibular loss. Unilateral loss causes imbalance due to an unequal input between sides, often leading to tendency to fall towards the affected side. Bilateral loss removes the sense of gravity and disrupts reflexive eye movements, leading to oscillopsia, which is a sensation that the world is bouncing during movement. Now, let's shift to the central vestibular system. Activation of central vestibular system can produce changes in posture, head orientation, eye movement, autonomic responses like nausea, and even consciousness. The central nervous system includes the 4 vestibular nuclei, multiple pathways, and vestibulocerebellum, and the vestibular cortex. These structures will integrate sensory input and coordinate motor output. The vestibular nuclei connect to the cerebellum, to eye movement nuclei via the medial longitudinal fasciculus, or the MLF, to the spinal cord via the vestibulospinal tracts for posture, and to the cortex through the thalamus for conscious awareness of head position. In terms of motor control, the vestibular system contributes to gaze stabilization through vestibular ocular reflex and to postural adjustments through the vestibular spinal pathways. Disorders of the central vestibular system are caused by damage to these brain structures and often produce milder vertigo, but more widespread neurological symptoms. Causes can include stroke, tumors, cerebellar degeneration, multiple sclerosis, and Arnold-Chiari malformation. Lesions above the vestibular nuclei can lead to abnormal perception of vertical without vertigo, resulting in head tilt, position, and postural misalignment. Other central conditions include vestibular migraine, persistent postural, perceptual dizziness, and disorders affecting postural vertical. Sorry about that. And postural vertical, where individuals were misperceiving their alignment relative to gravity. Clinically, it's important to distinguish between types of dizziness, such as vertigo, near syncope, disequilibrium, and lightheadedness, because each has a different causes and treatments. Finally, let's discuss rehabilitation. Rehabilitation focuses on three main strategies: movement retraining, habituation, and substitution. Movement retraining involves practicing and modifying movements. Habituation uses repeated exposure to symptom-provoking stimuli. Substitution relies on alternative sensory inputs or strategies to maintain function. To wrap up, the vestibular system is essential for balance, posture, gaze stabilization, and spatial awareness. It integrates complex sensory input and coordinates motor responses to keep us oriented and stable in our environment. Thank you for listening to the podcast.